Saurabh sir?
Yes,
Saurabh sir?
I'm there, sir.
Sir, can you, could you switch on your, hi, got it.
Is it okay, sir?
हाँ ठीक है, it's fine.
Done, sir.
अच्छा ठीक है, it's good. फिर okay, I'll oh, ma'am is also come. Ma'am is also joining us now right away.
Which ma'am, sir?
First speaker,
Okay.
Honorable Vice VC ma'am is also joining us.
Yes, thank you very much. I've joined.
Ma'am, very good afternoon, madam.
Good afternoon.
Ma'am, this is
Nice to see you. Yeah, I know you're Dr. Kannan, right?
yes, ma'am.
I know.
And
Nice to
ma'am,
see you.
and your moderator for today is Professor Saurabh, Community Medicine from
Okay.
our sister concern Sathya Sai Medical College, madam.
Okay, I see him also there.
Yes, ma'am, he is
Good
there.
afternoon.
Yes,
Good
ma'am.
afternoon.
Good afternoon. Ma'am, we have made you as a co-host, madam.
Okay, for screen sharing, right?
Yes, ma'am. Yes, ma'am.
Yeah. Okay. Thank you. Thank you.
Okay, 5 minutes, ma'am. I think we'll just talk to Vijayaraghavan sir.
No problem. No problem. I thought I'll join in so that it saves tension for the organizers, like,
Thank you so much.
connectivity issues, and then so many things.
Yes.
Yeah, you
Ma'am.
go about. I'll keep looking at my work. When you say start, I'm ready.
Yes, ma'am.
Right?
Yes, ma'am.
Yeah.
Ma'am, usually by 2:20, like a trailer, we run a trailer for 10 minutes, ma'am,
Okay.
about the university and all that.
Please do ahead.
That is for 10 minutes, and after that, we will be able to.
Fine. Please go ahead. I'll cut my video off. Okay.
Yes, ma'am. Yes,
But
ma'am.
I'll be hearing you.
Hanji.
I'll cut my video.
Ma'am. Thank you. Saurabh sir, I'll talk to Vijayaraghavan sir, and I'll revert back, sir.
Sure, sir. Sure,
At
sir.
2:21, we will start, sir, sharp.
Done, sir.
There's a numeric password also.
Simon said she was reported or taking the switch off mute.
Saurabh sir, you're on.
Okay, sir.
Can you please switch off. Yeah.
Hello, everyone, and good afternoon to all. I welcome the three honorable vice chancellors, Dr. Vijay Raghavan, Sri Ramachandra Institute of Higher Education and Research, Dr. Sudha Seshayan, honorable vice chancellor, Tamil Nadu, Dr. MGR Medical University, and honorable vice chancellor, Dr. Subhash Chandra Parija, Sri Balaji Vidyapeeth. I also welcome all the participants to the today's 11th national webinar as a part of SBV CONNEcT initiative on the topic creating a better normal and improving the health for everyone during COVID-19 pandemic. Myself, Dr. Saurabh Srivastava, professor in community medicine and medical education unit coordinator at Sri Sathya Sai Medical College and Research Institute, a constituent unit of Sri Balaji Vidyapeeth, deemed to be University, Puducherry. As we all know, good health is a precious thing. When we are healthy, we can learn, work, and support ourselves as well as our families. The COVID pandemic has jeopardized each and every aspect of human lives, including our livelihood. However, we cannot and should not allow the disease to continue to create havoc in our lives, and thus there is an indispensable need for active intervention and becoming more responsible. Thus, in the hope of creating a better tomorrow and simultaneously improve the quality of lives of everyone during this prolonged pandemic, let's listen to the view of three eminent speakers, and I'm pretty much sure that after listening to their thoughts, we will be quite empowered in discharging our roles and responsibilities. On that note, we have three important sessions lined up today. Let's move on to the first session of today's webinar on the topic role of health sciences universities in implementation of the new guidelines from the government, the 3 T's, test, track, treat for COVID-19 pandemic. And for this, we have a very apt person to talk about, Professor Sudha Seshayan, Honorable Vice Chancellor, the Tamil Nadu Dr. MGR Medical University, Chennai. So just to know about ma'am, she is a very renowned person, a senior faculty of the prestigious Madras Medical College, and has served as the director and professor of Institute of Anatomy at Madras Medical College. She has been an outstanding academic record holder, being a topper in the post-graduation with a teaching experience of more than 30 years. In addition, she has served the university as its registrar and has a rich administrative experience and an outstanding background, including the post of the vice principal of the Madras Medical College, and also been a member of premier editorial review boards for Gray's Anatomy, and continues to be a member of the International Advisory Board for reviewing the publication. She has been presented with the Best Administrator Award by the university. She is a dynamic woman who has mastered various roles with quite ease. She pursued her bachelor degree in public administration from the Osmania University and hospital administration from Annamalai University. Ma'am takes full credit for being the first publishing editor of the translated version of Encyclopedia Britannica in Tamil. Her write-ups in popular Tamil magazines on various spiritually oriented subjects are much sought after. She is currently involved in the preparation of a Tamil lexicon in medicine for the virtual Tamil University as a member of its editorial board. So with all that background, it's over to you, ma'am. Welcome, ma'am.
Afternoon.
Yeah, good afternoon, ma'am.
Most respected Professor Subhash Chandra Parija, Professor Vijay Raghavan, Dr. Saurabh, Dr. Kannan, all the dignitaries in the meeting hall, faculty members, and students. At the outset, my very sincere thanks to the organizers of this webinar for making me a part of this memorable occasion. Before I proceed, kindly permit me to share my screen. Is the screen seen now?
Yes, ma'am, it is visible.
Yes, thank you. COVID-19 pandemic, as rightly pointed out by the moderator, has changed the entire world. The way we think, the way we act, the way we move, everything has changed. And it is also a situation that we have realized mankind will have to move as a single team, put in collective efforts to combat this virus. And I fondly hope it is with this idea in mind that the Sri Balaji Vidyapeeth has thought of this webinar, so that all our collective efforts would go to create a better normal and improve the health for everyone during this pandemic. The topic assigned to me today is that what could be the role of health sciences universities in the implementation of the new guidelines? The new guidelines talks about 3 T's. And what are these 3 T's? It says test, track, and treat. Test for COVID, track those with COVID, and treat those who are affected. Let's take each of these T's. And friends, this afternoon, I don't indulge in a very detailed discussion about these 3 T's for 2 reasons. One, people who are in the health sector are already involved in these and know pretty much more than what could be discussed in a public forum like this. Reason number 2, I would want to kind of concentrate on the role that a health university can have in these 3 T's and not go into the details of testing or tracing or treating. If we take each of these components, what do these components mean to a health university? Let's take testing first. Why is testing needed? And having been into the pandemic for over 365 days, do we all feel that testing is significant? Or is testing always significant this way it had been once or twice? And what can a health university do? Now, why is testing needed? Whatever kind of reasons we could accord for the necessity for testing, the most important of all these reasons would be testing would guide us to the appropriate triage. What could be the further course of action when a particular individual is encountered either symptomatic or asymptomatic? Testing would lead us to the next step of action. Is testing always significant? We still are not sure. We have heard about false reports. If the individual is tested during the window period, the reports could vary. That apart, there are very many unknown factors which seem to be playing a lot in the results. Unknown factors with regard to the viral genome, unknown factors with regard to the way the viral variants behave, unknown factors with regard to the host response, unknown factors with regard to heparin-induced thrombocytopenia, and so on. There have been instances where someone tests negative. However, the very next day, within about 24 hours, CT would tell us that the lungs have been involved for more than 50%. The CORADS is high. So in what way could we decide if testing is equally significant? We cannot. There have been variations. However, it would not be correct to say that testing can be done away with. We'll have to remember that this virus is new to us. The entire history of the virus had just been about over a year or so. We are learning. Every day we learn. Whatever our experience or mankind's experience had been with viruses like the pox virus and so on, let's remember smallpox had been there for about 12,000 years with mankind. And it was after 12,000 years that mankind was able to do something about it. We do not have that kind of a time with SARS-CoV-2. So whatever is the status, whatever is the kind of variability, it still will have to be remembered that testing is important. And with the resurgence of what may be called the second wave, we do find more people are asymptomatic. People belong to the younger age group, and there seems to be a widespread transmission. All of these lead us to the conclusion that testing is extremely important, even in this advanced state of the pandemic. What can a health university do here? Individual centers have been testing. There had been individual laboratories. Everyone wants to do something, so everyone plunges into activity. Probably the health universities, which are regional, can coordinate the efforts of these individual centers. Thereby, the number of centers which cater to the demand of the public would be increased. There could be pooling of resources. One of the difficulties that we have been facing, not necessarily Tamil Nadu or India, but the entire world had been facing, is lack of resources at the right time. Lack of right kind of resources at the right time had been the problem for the last 1 year over in our experience with COVID-19. So pooling of resources, pooling of manpower which is getting exhausted, which is getting fatigued, could probably be helped if manpower is pooled. Most important would be to coordinate the results and the result parameters. I'm sure Professor Vijayaraghavan would remember early in the pandemic, even the result parameters varied. There were some laboratories which said if the CT score is over 35, the cycle threshold score in the RT-PCR, if it was over 35, they would declare someone negative. But then there were laboratories which said, no, we'll only wait for 42. Only if it is over 42, we'll declare it negative. So the kind of variability amongst various laboratories, amongst the kind of thinking, sometimes the kind of material that gets spread across, with the social media being very active, the kind of information that gets spread across, I think the health universities can jointly decide and standardize on the result parameters and coordinate the results, try and kind of give a picture. And maybe there could be regional variations, like in certain areas, if the CT is over 35, it could still mean something. In certain areas, it could conveniently be on the negative area. So it could be probably a kind of a coordination that the health universities can do. Now, coming to the second factor, tracing, level of tracing, time of tracing. factors that modify tracing. Now, level of tracing, I tend to go into this as we stand today in the pandemic, in the resurgence of the second wave. There need not be tough efforts to contact the traces. Early in the pandemic, it was difficult. If someone traveled from Delhi to Chennai by flight, most of us would remember the flight operators were asked to trace the passengers who traveled in the flight. And then maybe after 3 days, 4 days, someone who traveled and thought everything was over and was well settled was contacted and then asked to go for testing just because someone else in the same flight had tested positive. I think that kind of tough efforts are not required any longer. We don't have to bother about sporadic contacts or travel contacts or short exposure contacts, but then concentrate on close, long-term exposure, long duration exposure, and coexistent contacts. Why do I say this? There is a particular reason that we need to see here. The recent trend as far as the COVID clinical cases are concerned is that there had been family clusters. We find there is a kind of entire family reporting positive or reporting symptoms. Very often it is that one person reports, the father or the mother or some elder, after which we find the entire family comes in after 2 days, 3 days. We've seen families where even a 10-year-old boy had been involved, and then another family where a 6-month-old child tested positive, all 3-4 days after the eldest member of the family became sick. Now, the reason for this kind of a family clusters, various theories had been put forth. People had been thinking about a kind of a viral variant behavior and then epidemiological variations. But then the most plausible and the most important will have to be what we think about is the in-house transmission or inside spread. It is a very simple name, inside spread. What does this mean? People who dwell in the same room for long hours. My clinical colleagues tell me when a family presents, it is usually the husband and then the wife. The husband and the wife, the couple who use the same room for long hours, for 12 hours in the night or 10 hours in the night, they slept in the same room, or pre-teen siblings, children who sleep in the same room, not necessarily a college-going girl and a college-going brother of hers, but then in the age group where they tend to share the room, we find they are affected in clusters. So the mathematics is very clear here. Time of exposure multiplied by the distance in between the two individuals, multiplied by the activity. Activity here means talking, coughing, sneezing, and things like that. You sit in the same room, keep talking to one another, maybe very close relatives, but then a kind of a confined environment, not much of ventilation, use the air conditioning, want to watch a movie in the TV, watch 2 movies continuously for about 6 hours in the same room, keep talking to one another, commenting about the movie. There is absolutely no external ventilation. The distance between the two is very minimal, sitting and yakking away to glory, eating some snacks. Now all this, now the snacks is not the culprit, yakking is not the culprit, but then the time of exposure multiplied by the distance between the two individuals, multiplied by activity that they are involved in, multiplied by the enclosed atmosphere. Open ventilation would reduce the risk. So what we now advocate is, even to doctors who are practicing in their consultation rooms, we tell them, keep your fans on, switch off your AC, keep the windows open, let there be absolute planar ventilation. And then Even if you need to talk to your patient, see to that your discussion does not exceed 15 minutes maximum time. Send the patients off in 15 minutes. So a kind of a short discourse. And the other important factor is keep the mask up even inside the house. Even inside the house, especially when an individual of the house, a member of the family, goes out and comes in, goes to the office and comes in, the wife does not go, the husband goes to the office and comes back, the husband could still be transmitting, that could be a closed cluster, so keep the mask on. So in these circumstances, I think the level of tracing is not that very difficult. Factors of aerosolization will have to be remembered. Under ventilation, especially in a country like ours with tropical climate, where we tend to think summer is on and try to switch on the AC and underventilate ourselves, and the factor of clustering. Now, again, if the level of tracing is easy, has become easier, the time of tracing is also becoming easier, because as early as possible, early in the pandemic, tracing someone was difficult. A fellow traveler would have gone to Coimbatore from Chennai, and then the other person who had tested positive would have remained in Chennai. Tracing the person who had gone off to Coimbatore or by road elsewhere would have been much more difficult. But now, because it's family clusters, it's easy. As early as possible, tracing could be done. Duration of exposure will be a key factor in determining the contact tracing. Now, the health universities can involve the students. Pardon me, I think students will have to be made more responsible. I do find many of these children are those who do not don the mask properly. So probably we would have to make our own children more responsible, our own students and trainees. Tracing can be easily done even telephonically, because it's going to be well within the family or well within the apartment complex. Factors which have modified tracing strategies, summarizing on the earlier two, these are the factors which have modified the tracing strategies: clustering, families together, air conditioning being an aid to aerosol, because we all know there is still some kind of aerosolization happening. The aerosolized virus will remain active for about 3 hours and at a distance of about 6 meters. Aerosolized small droplets would remain active for 15 minutes at a distance of 6 feet even. Large particles on the objects, on fomites, duration is variable, but then please are for a still environment. If there is ventilation, that would definitely help. So under ventilation factor will have to be removed. Longer, closer contact will again modify our tracing strategy. What I called inside spread is what is happening, in-house spread, if I say it in a corporate style. Treating, the third T is treating. Protocols, academic exchanges and stratagem modifications, standardization and dissemination are areas where a health university can help. Trials, various kinds of clinical trials, research trials, genomic studies could be part of the university work. And then fixing and instructing, fixing the protocol. Now in the Rajiv Gandhi Government General Hospital at Chennai, quite early in the pandemic, once we fixed some of the protocols, we resorted to a very simple technique. It is not something to do with 4th generation, 7th generation, 17th generation computers. It's a very simple technique. What was done was the protocol was printed on pieces of paper or on certain sheets, and these were pasted across on the walls, making it easy for even a junior to look at the protocol and go about the next step. There was no necessity. See, communication, though we say communication is easy, communication is becoming difficult in times of these. It is not possible when you have COVID patients for the doctors to communicate with one another even. Sometimes it's extremely difficult when you go from one corner to another corner with all the PPE and other things. So this was a very easy way. The protocol was just pasted on the wall. The universities can decide on the protocol, coordinate, and kind of give common instructions, because what I find still, even in a city like Chennai, there are small hospitals which are struggling. Not enough space is available in large hospitals. So people will have to be accommodated in small hospitals when they are asymptomatic or when they have mild symptoms. But then small hospitals find it very difficult. They do not know what is the next protocol, because large institutions have decided, but then small hospitals have lost the race. So somewhere the universities can coordinate and kind of, run a kind of center where information will be available, a phone call, and then over phone, a proper protocol could be told with monitoring, not without monitoring, but with monitoring, some kind of help, academic help and treatment help could be done. Academic exchanges through the university is simpler with various sources and establishments. In our university, we established contact with the Royal College of Surgeons and Physicians in the UK, with the Singapore-based government health system, with the UK NHS, with the CDC Atlanta, and several other centers. And that is how we decided some of our protocols and some of our routines. Integrative techniques, the universities could think of integrating Indian systems of medicine, alternate systems of medicine. We all know the kind of immune, the Siddha formulation in giving us evaluation of all these methods and measures and modifying the strategy as required. Standardization, dissemination, which is a summarized thing of whatever had been told earlier, drugs, protocols, wider dissemination, faster triaging, aware already situation. Now, if universities can coordinate, health universities can coordinate, there could be a particular case scenario which nobody in Chennai or Puducherry would have seen. But then the same case scenario would have been seen in Mumbai. We already have a situation where we would be aware of the scenario. We don't have to suddenly panic. Now, this kind of coordination can be done by the health university. Apart from the 3 T's, my dear friends, the most important T that I would want to add today that a health university should now bestow its attention upon is T for teaching. Now, please don't frown and look at me and say, we are into online classes. We don't have the kind of an ambience for regular routine teaching. So why does teach or teaching come here? Now, what is this teaching that I would want to stress upon? Health universities are doing research. Health universities are involved in treatment. Health universities are testing. Health universities are contact tracing. All that is happening from day one. I'm sure Professor Vijayaraghavan had been doing this. Professor Parija had been doing this. Dr. Kannan had been doing this. Everyone, every member of the health and the health sciences fraternity has been doing this from day one, or from the day a COVID index case was reported in India. But then what is this teach that I would want to emphasize on? Teach prevention measures. IEC, our IEC will have to become more and more aggressive. All of us would agree this resurgence is primarily because of a lack of coordination in COVID appropriate behavior. Let us not go into the details of what exactly happened, but we all know prevention measures were kind of kept away. COVID appropriate behavior was cast away, and that is where we are with this kind of a resurgence. Prevention measures, COVID appropriate behavior, awareness spread. All this will have to be done. And I would say this is where the Health University will have to step in. Number one, if you're running online classes, please make it mandatory that the first 3-4 minutes of your online class, whoever it is, whether it is a medical postgraduate or a BSc Allied Health Science class or a dental class, whatever is the class, see to that the first 3-4 minutes is spent on some kind of a PowerPoint presentation or a video presentation on COVID appropriate behavior. Yes, they might know it, but let's repeat it for the simple reason, human psychology is that unless we hammer, it refuses to budge. So this has to be hammered again and again. Every online class, let's do this. Let's involve our students to do some kind of dissemination work. They don't have to go out into the society. They don't have to go out in the open. They don't have to be running on the road to do this. They probably can take their phone, call up 2-3 of their friends and say, have you remembered to wear your mask today? Have you remembered to keep your doors open today? Have you remembered to have proper ventilation today? That would have a cascading effect. If 4 of them do that, it's going to be 4 into 4 minimal, 16 people getting the information. 1 lakh students in a health university, I'm sure the cascading effect will not necessarily go to 4 lakhs, but at least to 3.5 lakhs. Awareness spread. Let the pharmacy students, the nursing students, allied health sciences students, everyone be involved. In fact, we in our university have started an initiative yesterday. We have requested all our students, especially those students who are sitting at home because of online classes, not able to come into the institution. We have asked them, just do a small poster. It can be a handwritten poster. You don't have to spend expensive material. Just write even in a sheet of paper something about COVID appropriate behavior. Just write, wear your mask regularly or wear your mask properly, cover the nostrils and cover the mouth, and kind of display it in front of your house or display it in your apartment complex, display it in the parking of your apartment. 4 people look at it, 10 people look at it, people keep looking at it again and again, they start behaving. So this is the teaching. This is the 4th T dimension that I would want to add to the 3 T's which are already existing. And I'm sure that would go a long way. Involve the staff and the students in aggressive IEC, widespread awareness steps, non-expensive, small-scale steps which will have a cascading effect, and make it part of educational responsibility. Friends, we all have been talking about social responsibility for many years. And then the last 2 decades, we have been talking about CSR, corporate social responsibility. Let us turn around and ask our own selves, what is educational social responsibility? ESR. ESR will from now on not necessarily mean erythrocyte sedimentation rate, but let it mean educational social responsibility. As members of the health sciences fraternity, we have a responsibility to the society. And that is what our professional education should give us. And let's be part of this ESR. So in tune of that ESR, I would say the Health University has a big resource potential. And this resource potential can be used if we all jointly put our hands together, and the collective responsibility would give us more and more light. Thank you.
Thank you, ma'am. That was a very wonderful session filled with all practical experiences and real incidents. It gave a lot of insights about the role of health sciences universities in effectively implementing the guidelines released by the government. Actually, ma'am has enlightened us about the role of health science universities in strengthening the 3 Ts which are already existing, especially with regard to prompt testing to diagnose the potential cases, the process of contact tracing to identify all the close contacts, and finally, the early initiation of treatment to minimize suffering, complications, and even death. We totally get your insights about the 4th T, and I assure you, ma'am, that we will try to adhere as well as apply them in our daily schedule for the cascading effect. Thank you, ma'am, once again for your session.
Thank you very much.
Yeah, ma'am. So without spending much time, let's move on to the second session for today, which is on the topic building a fairer and healthier world during the COVID-19 pandemic. And for this, we have our very own Professor Subhash Chandra Parija, Honorable Vice Chancellor, Sri Balaji Vidyapeeth. Sir is an eminent academician, erudite microbiologist, avid researcher, keen votary of medical education, and an able administrator. Sir has served earlier as the director of JIPMER, Pondicherry. Sir has been the author of 16 books and in excess of 400 research papers in national and international index journals. He has been listed among top 2% of scientists globally in the field of tropical medicine. Food and Agriculture Organization WHO expert member on foodborne parasitic diseases. Sir is one of the few persons to receive Dr. B.C. Roy National Award MCI in the year 2003 for his nodal contribution towards the development of medical microbiology. Sir is also the founder of the Indian Academy of Tropical Parasitology and has been conferred with various fellowships and other degrees like FIMSA and so many and so on, FICAI, FABM, etc. and etc. So I invite our Honorable Professor Subhash Chandra Parija for his talk. It's over to you, sir.
Good afternoon.
Good afternoon, sir.
My dear esteemed members of these speakers for today's webinar, respected Professor Sudha Sen, esteemed Vice Chancellor of the Tamil Nadu Dr. MGR Medical University, Chennai, esteemed Professor Vijay Raghavan, respected Chancellor of Sri Ramachandran Institute of Higher Education and Research, deemed to be University Chennai, and today's coordinator, Professor Saurabh, above all dear participants in today's webinar on creating a better normal and improving health for everyone during COVID-19 pandemic. At the outset, on my behalf and behalf of the entire fraternity of Sri Balaji Vidyapeeth and our Chancellor, Sri M.K. Rajgopalan, I extend a hearty welcome to you all for this interesting webinar in this backdrop of second wave of COVID, which we are facing now. I must thank profusely my predecessor, Professor Sudha Sen, who has nicely conveyed the message, the importance of teaching and teaching. And she has rightly mentioned the role of health sciences universities in educational social responsibilities to convey the message during the second wave of pandemic 2019. Today, I'll be sharing some of my thoughts on building a fairer and healthier world during COVID-19 pandemic. I'll try to cover my presentations within 20 to 25 minutes. I'll do that first. I'll give a brief introduction about this talk, about the second wave of pandemics, and then I'll try to identify various implications of COVID-19 we are facing since last year, and discuss the way forward suggested by international health bodies like WHO, and what are the areas, high priority areas in which all health sciences university has an important role to play. This COVID-19 pandemic has brought many things. It has brought us to realize many things. But one most important thing that it has re-emphasized and made us to realize that our world is an unequal one. Because as this COVID-19 has highlighted, some people are able to live healthier lives and have better access to health services than others. This is entirely due to not any other factors, but due to conditions in which they are born, they are growing, they are living, working, and of course the age. It's a common scenario all over the world. Some groups struggle to make ends meet with little daily income, have poor educational status, less employment opportunities, and limited access to a safe environment, clean air, clean water, and food securities. Hence, all these have contributed definitely to unnecessary suffering, which can be avoidable, and avoidable premature death. And definitely, in course of time, all these have harmed our societies and economics. With this COVID-19 pandemic, now we must understand it is the high time that everyone has living and working conditions that are conducive to good health. In addition, one must ensure that all people are able to access quality health services when and where they need them. Since last year, this COVID-19 has affected all the countries, but of all the people who have been affected, there are some selected group of people who have been most affected, which one group is vulnerable group of populations. That includes senior, old age people who are much more vulnerable to these conditions. Second group, the people who are exposed to the disease, frontline workers like health workers and other professionals. And definitely the group of communities who like or who have access to quality healthcare services. Hence, the most important component of a good health that everyone, everywhere can realize this good health. As we know, this COVID-19 pandemic COVID-19 outbreak was declared as a pandemic on the last year, 11th March. Since then, it is continuing to spread, has continued to spread, and is responsible for massive disruptions in different domains and human lives. As of April 2021, this year, this disease has been reported across 223 nations and territories. This pandemic has highlighted the fact that we are less prepared to meet these emergent situations. Within countries, illness and death from COVID-19 have been higher among groups with poverty, social exclusion, and particularly adverse daily living and working conditions. It is estimated due to this pandemic throughout the world, average 120 million people have gone to the poverty last year. Also, the ongoing pandemic has accounted for widening of the gender gaps in employment. Some studies have revealed that the women exiting the labor force are in greater numbers than in men over the last 1 year. The resulting inequities in people living conditions, health services, and access to power, money, and resources have also resulted in significant deterioration of many health indices. To mention few health indices like mortality under 5 among children from the poorest households are double that of children from the richest households. Life expectancy for people in low-income countries is 16 years lower than for people in high-income countries. These are the unfortunate implications of COVID-19. But definitely, with this background, we must move forward. As countries continue to fight the pandemic, a unique opportunity emerges to build back better for a fairer, healthier world by implementing existing commitments, resolutions, and agreements. Hence, it is much more important to invest in strengthening health services. And moreover, that would help to remove the barriers that prevent so many people from using them, so more people have the chance to healthy lives. In this context, World Health Organization has identified 5 important areas to build a fairer and healthier world during this COVID-19 pandemic. First and foremost is to accelerate equitable access to COVID-19 technologies between and within countries. As Professor Shura Sasar nicely mentioned, technology in terms of testing, RT-PCR testing for virus, other technology for vaccines, and vaccines for the treatment of these things, all technology-based activities. Second important component is to invest more and more in primary health care and prioritize health and social protections. Fourth priority area is to build safe, healthy, and inclusive neighborhood. And last but not the least is to strengthen data and health information system. And when we think of priority 1, we are definitely happy and proud that in our country we have Covaxin and Covishield, 2 indigenous vaccines that has been developed and approved at a record speed. Until now, more than 10 crores of populations have been vaccinated with these vaccines. So now, with this availability of the vaccines, we must ensure that they're available to everyone who needs them. In the first, the vaccine was given a priority to frontline workers. Then subsequently, it has opened up to people of 45 years and plus for the vaccines. Now, already Government of India announced that from 1st May, that 18 years and above, all will be given vaccines. All this indicates that the commitment of the government to ensure that they will be available to most of these people in our country. And definitely, in this need for so much of high doses of high vaccines, we hope to augment the production of cost-effective vaccine so that the vaccine can reach most of the people in India worldwide. But we must understand vaccine alone won't be sufficient to overcome COVID-19. These other supporting materials, supporting treatment conditions should be appropriate, and commodities like oxygen and personal protective equipment, as well as diagnostic tests and medicines. Availability of all these things in large quantity is most vital. So there would be a strong mechanisms to fairly distribute all these products within the country so that the infected, affected persons are given the best care. Thus, there is a need for a strong and streamlined mechanism to ensure equitable access to all these essential products. Now, second priority of WHO is to invest more and more in primary health care. As we know, global estimates at the present mentions that at least half of the world population still lacks access to essential health services. More than 800 million people spend at least 10% of their household income on healthcare. And there are alarming estimates and hence needs to strengthen this primary health care because evidences are growing. And they show that primary health center-oriented health systems have produced better health outcomes, enhance equity, and improve efficiency. Scaling up PHC interventions across low and middle income countries could save 60 million lives and increase life expectancy by 3.7 years by 2030. And invest in private healthcare includes creating at least 10 million additional full-time jobs globally and strengthening gender equity efforts. Women deliver most of the world's health and social care, representing up to 70% of health and care workers, but that deny equal opportunity to lead it. Hence, key solutions include equal pay to reduce the gender pay gap and recognizing the unpaid healthcare works by women. Third priority is prioritize health and social protections. In many countries, the socioeconomic impacts of COVID-19 through loss of jobs, increase in poverty, disruption to education have exceeded the public health impact of the virus. Some countries, of course, have already put in place expanded social protection schemes to mitigate these negative impacts of wider social hardship. And another most important priority would be to build a safe, healthy, and inclusive neighborhoods. It would be important to intensify efforts to reach rural communities with health and other basic social services, including water and sanitation. And last but not the least, priority is that these communities urgently need increased economic investment in sustainable livelihoods and better access to digital technology. Increasing the availability of timely, high-quality data that is disaggregated either by sex, wealth, education, or ethnicity, and place of residence is to key working out where inequity exists and addressing them. Health inequality monitoring need to be an integral part of all the national health information systems. A recent WHO global study has shown that only 51% of countries have included data disaggregation in their published national health statistic reports. The health status of these diverse groups is often masked when national averages are used. Moreover, it is often those who are made vulnerable, poor, or discriminated against who are the most likely to be missing from the data entirely. Hence, to conclude, for a fairer and healthier world, particularly during this COVID-19 pandemics, has given us a time to introspect, and also it gives an opportunity to make all of us to move in the directions so that, but the end outcome is that it is the now time to invest in health as a motor of development. That needs more emphasis. We need to choose between improving public health, building sustainable societies, and adequate nutrition, and having thriving local economies. Definitely, all these only vital outcomes would go in hand and need to be given due attention simultaneously. That would contribute in a long way for the building a healthier world, healthier country in this pandemic, COVID-19 pandemic. Thank you. Thank you very much for your patience here.
Thank you, sir. Thank you very much. That was quite an informative and enlightening session, like always. And what I personally liked the most is like being a public health professional. It was on the lines of World Health Day 2021 theme. So as sir succinctly talked about some of the aftermaths of the COVID-19 pandemic, it is high time that we all stand together to overcome the fear and anxiety associated with the disease. We must realize that the disease of such magnitude cannot be contained by the health sector alone, and therefore we will be needing a multi-sectoral approach. This essentially includes the support of food safety, travel, trade, research and development, community, and all, eventually to build a fairer and healthier world. So thank you once again, sir. Let's now move on to the third and final session in today's national webinar on the topic coexistence of hybrid teaching in health science universities during COVID-19 pandemic. And for this session, we have with us Honorable Professor Vijay Raghavan, Honorable Vice Chancellor, Sri Ramachandra Institute of Higher Education and Research, Chennai. Sir is a joint replacement surgeon with more than 38 years of experience in India and abroad. Sir has served more than 30 years of experience as a practicing orthopedic surgeon in various capacities in teaching and non-teaching hospitals. He had developed special interest in joint replacement surgery since 1978 and had undergone special trainings while in the United Kingdom and further advanced with specific training both in India and abroad. Sir held various administrative posts like Director Academic Administration and Dean Education at SRMC campus. He is a member and fellow of various orthopedic associations and fellow in medical education and expert member for MCI faculty development. The most important achievement has been that he has been appointed as the convener, Nodal Center for the Medical Education Technologies, recognized by the Medical Council of India for conducting basic and advanced faculty development programs, including fellowship in medical education. Sir has more than 30 scientific articles in national and international index journals in orthopedics and in the field of medical education. Sir has delivered orations and special guest lectures in various state, zonal, national, and international level orthopedic conferences and in medical education programs. Sir has been awarded with the Best Teacher Award, Certificate of Excellence for Outstanding Service, International Friendship Society in the year 2001, and Fulbright Scholar. So with that, I request Honorable Professor Dr. Vijay Raghavan to please start with his session. It's over to you, sir.
Thank you, Dr. Saurabh. Are you all able to hear me?
Yes, sir.
Yeah. Let me at the outset congratulate Sri Balaji Vidyapith and my good friend Professor Subhash Chandra Parija, the Honorable Vice Chancellor, Dr. Sudha Seshayan, the Honorable Vice Chancellor of the Tamil Nadu Dr. MGR University, Dr. Kannan, and my other friends at the Mahatma Gandhi Medical College, and dear participants. It has been quite interesting for me over the last 1 hour listening to two stalwarts in Dr. Sudha Seshayan and Dr. Parija, and quite a lot of learning that one can do out of these talks. Let me just introduce my topic by saying that there is a lot of need for sort of bridging the gap between education and healthcare. And I think this has been realized over and over again, and as rightly brought by Dr. Sudha Seshayan, that at the end of her talk, she finally landed up by projecting one slide completely on teach, teach, and teach. So there is always a connectivity between treatment, research, and education, and all three needs to be sort of brought together. Let me now share my slides, and we will go through the topic that has been sort of allotted to me on coexistence of hybrid teaching. This also can be called as blended learning in health sciences universities during COVID-19. In fact, COVID-19 has made us all richer and also more competent to deal with many of these requirements. So I plan to sort of discuss this subject under those headings. Initially, one slide at least on the problem of the pandemic, which all of us are aware. Where do we stand with presently the second wave? What has the pandemic affected in terms of education, economy, entertainment, engagement, or even e-health? Each one has had its own profound effect, and it's important that we consider many of these aspects as well. Now, are the learners and teachers any different from what they were, say, 20 years or 40 years or 50 years back? Is something which we also need to look at when they have to adapt to newer technologies and newer methods. And then we also have to consider, is health professional education different from arts education or the technological education that happens in the engineering institutions, etc.? I think there is a definite difference here, because most of our training at the end of the day is on the practical ground in the hospital with patients and things like that. Of course, there are lots of in-betweens that have been introduced now, which can create simulated environment for us to learn. But whether the entire health professional education can be made online is a question mark. And that's something which we need to consider. Has COVID brought in an ICT revolution? I think ICT revolution has happened almost for the last 20 years. And if you look at medical education, probably this started happening somewhere around 2009, 2010, when the competency-based education was sort of thought about. And when it has been introduced in 2019, it has picked up further. how do we sort of break even with all these differing requirements through what is called hybrid learning, which is the subject of today's topic, and also we can call it as blended learning. And what has been some of the practices that Sri Ramachandra Institute of Higher Education Research has introduced for people to be aware. I will just begin by going with the global burden of the pandemic, what we are facing today. This is the screenshot which I took from Johns Hopkins, the research center, which updates itself. And as of yesterday evening, we have almost about 14 crores 21 lakhs 94,528 COVID positive cases in the world, of which India has also contributed sufficiently high in the form of about 15 lakhs 321,089, about 1.5 to 2 million cases. And if you see the deaths, while India is slightly lower, still we have contributed almost to about 1.80 lakh deaths in this. Now, the subject is actually blended learning. And how do we understand our learners? Today's learners are all socially wired. They are the millennial learners, as we call. And you should see that during our time, when people like Dr. Sudha Seshayan, Dr. Parija and myself were young MBBS graduates, born between the year 46 to 64, we had most of our learning through something called course-based learning, or sometimes resort to even rote memorization and things like that. Then we went on to the next generation, where the Gen X, and these type of people always wanted some sort of a hands-on before they. So even as orthopedic surgeons or skilled surgeons, we had to adapt ourselves to more and more of practical aspects by attending quite a lot of workshops during your later days. So there is a definite change as the generations pass by, and they do have to engage in all types of learning and media as they grow in their learning process. Now, this slide actually sort of summarizes the way we learned. We were all under the group of the baby boomers, where our one point of learning used to be through the overhead projector, or the so-called early stages of PowerPoint projections. Sometimes we were given the advantage of going through case studies, some experience sharing, and group discussions has just about begun during our case discussions, etc. But the present generation, why millennials, they believe more and more of self-study, webinars, podcasts, and technology innovations in all their learning. So there is a sea change in the way education also has advanced, and a huge generation gap also exists, and we need to sort of look at all these things. Now, this information and communication technology, as people understand, has also grown over the years. Now, most of the institutions have adapted to some sort of a learning management system, which may be indigenously produced, or it may also have been sort of bought from standard softwares. And this has allowed education to happen through quite a lot of e-learning, quite a lot of assessment that also happens on the online itself, and a lot of documentation, courses and software are possible. Ultimately, we depend on even social media in the form of WhatsApp, Twitter, or Facebook for quite a lot of learning that happens today. So if you look at the COVID-19, some of the important aspects for understanding its epidemiology, it is behaving slightly differently in various countries. In the US, it has been different. In the UK, it has been different. In India and some of the South Asian countries, it has been different. Now, again, the pandemic conditions in India itself has varied. As you know, Maharashtra has had the brunt of the attack, and Mumbai has suffered the maximum. But then there are other states also which have all not fallen back. In a pandemic, almost every single place does get cases, and so that is something which has been slightly different in various places. Corona pandemic conditions progress over a period of time. As you know, we all thought India might escape the second wave. But unfortunately, it has come and struck us much more harder. And that is something which we also have to keep in mind. And if you look at the epidemiology in the various states, countries, it is slightly different. Of course, the vaccine has developed, and there are several types of vaccines that are now available across the world. And in India itself, there are 2 of them, and the third one also getting the sanction. We would probably have more and more people, and we as a country have done fairly well in almost about 12 crore of our population already having been vaccinated. There is a behavioral change that is required, which was beautifully brought out by Dr. Sudha Seshan, and that is something which we all have to follow in terms of wearing masks, in terms of hand sanitization, and in terms of maintaining social distancing. Now, these modifications should be sort of adapted, and some of the failures that happened should be looked into. Now, what are the various methods of teaching learning that are available to a healthcare university? And each one of us who are actually speaking at this have adapted different methods to see that our students have been engaged throughout this last 1 year period. And you know that we have to encourage online education and distance mode of education. There are e-health programs from which students can learn. There are also the mobile health programs which are in vogue. Then there are this many foreign platforms wherein you can bring in some of these online ward rounds, online operating rooms, etc. to the students, which they can watch and learn as the procedure is going along. And of course, the journal club, seminar, and symposia are the things that can be worked out. So in our own institution, we did adapt to the new CBME that has been introduced by the National Medical Commission. And we have got many of the teaching learning methods in the form of the alignment and integrated topics being completely discussed online. And some of the videos to make the students understand some of these systems have also been brought out quite well. The online student doctor learning methods can very well be brought out through the virtual ward rounds. And this is something which also has been practiced through our institution. There is possibility to have some breakout rooms, small group, Google groups being created where some small group activities can go on. There can be competitions which can happen online very well through poster making, games, quizzes, etc. Then there is this online problem-based learning, team-based learning. All these are now possible. Only thing is we have to run your imagination wild to see how students can benefit out of all this and regularly get feedbacks. If something has not worked, you'll have to see how best it can be worked. It is not very far off that we are going to have classrooms of this type, where the infrastructural needs of a classroom for 300 people may not be required, but you need a large screen with the teacher actually looking at the screen and teaching, and where the entire class is sort of brought out in the form of small photographs that is picturized as you see here. So it is not very far off that we are going to have things like that. Then there is this online grand rounds, and I'm just projecting this. I don't know whether it will work, where this sort of ward rounds can be done online. Actually, this shows that the London hospital starts virtual ward rounds for medical students, and it's an article where you actually have to wear this, what is called the HoloLens, and a flock of students stumbling after a consultant on a ward round has long been a familiar sight in hospitals, and this has been completely overcome by him being in the at his home or in the hostel, and where he is presented some of the pictures of the patient on rounds, and also his investigations like the chest X-ray, and these type of things will really make the student follow the rounds as it happens in real situations. So these are some of the things that are possible now. Of course, we do this for the COVID patients, and this has made us to realize that we can sort of communicate with the patient and the patient's relatives through video conferencing. So this is something which COVID has taught us, and many of the patients are quite happy to interact with the patients by not actually going near the patient, but from outside. Now, these are again the virtual reality medical skills training. As you can see, some of the endotracheal intubation, again by the virtual reality mode. Again, I'm trying to show this video of how exactly this works. So we have to be innovative, look at some of this and start projecting it to the students as they go on.
अयो काय ते लड्डूचे
Sir, we have lost you, sir.
So now it is almost possible to simulate virtually on every single procedure that one wants to demonstrate for the student. Similarly, there are technology available for with the type of HoloLens, which actually can sort of simulate and produce you an emergency or a virtual ER or a virtual labor room type of situations where you are expected to act upon. So actually, blended learning, what it means is that you provide opportunities for the students to come to the classroom at some point in time, but most of the learning happens through video-based learning and through e-learning and on a self-directed mode. And as the definition goes, it is just that courses that integrate online with traditional face-to-face class activities in a very planned, pedagogically valuable manner, and where a portion institutionally defined of face-to-face time is replaced by online activity as well. So this is some of the examples of what we have done at Sri Ramachandra, that I'm bringing a design of a blended learning. Like the content is divided by some video lectures, podcasts, articles, or some of the virtual reality videos that I showed, e-textbooks, external links, etc. Then we decide on what will come as face-to-face in the form of group discussion, presentation, debates, interactive lectures. Then it is well planned and well decided early on what will be the type of collaborative activities that will happen and what will be the assessments that will be done for each one of them. And there is a seamless integration of online and face-to-face session. And that makes the whole learning very interesting for the students. If there is no connect, then there is a problem. So we must be able to connect each of these sessions very well. And many of these online e-content videos, they should not be going on and on for 45 minutes and 1 hour straight away. They should have breaks of every 10-15 minutes where there should be possibility for interaction with the students. And there is also some sort of a repurposing the time and facilitators online presence. I will move on. So some of the questions to be asked while designing online activities are that how will the learning activity actually support the intended learning outcomes? So once you have defined the learning outcomes for a particular session, what are the activities that will sort of enable you to get these outcomes? What will motivate the learners to engage in online activities? There are some people who are still not savvy with net connectivity. So how are you going to sort of make them learn and also to practice? How can the facilitator motivate the learners and encourage the support each other in online learning? How are you going to support each other? Because quite a lot of group learning also happens in online learning. Can a learner's activities and tasks be incorporated into continuous assessment? This is quite possible. See, a lot of things that happens, even today, this webinar, it is completely recorded. So once it is recorded, you can always go back and look at what all happened. Similarly, some assessments, if they are introduced, they are already recorded. So you know that how many students have actually answered and how many students are still to do it, and you can easily take a feedback. So this is a module which we developed for coronary artery disease, where we kept the learning outcomes as that at the end of this module, the learner should be able to discuss the etiology of coronary artery disease. That is sort of basic science. Now explain the diagnostic pathway. This will include combination of basic science with clinical science. And lastly, a component of actual treatment part has also been brought in that discuss the medical and surgical management of coronary artery disease. So once these outcomes are defined 3 in number, then you can sort of divide that into what will happen through video lectures. And there are some topics that have been given there, how it can come, face-to-face interactive learning, what will happen there, and what will be the small group discussion. So almost a 1 hour session can be planned almost on a 10 minutes or 15 minutes basis. And we keep the Miller's pyramid as our baseline in sort of advancing the student from a beginner to expert by going from just the know-how to shows how and actually does by using some of these techniques. Some of the surgical videos of actual coronary bypass can easily be shown. This is just a video which shows a simple hand washing technique. And so that is something which we also can look at. So there are definite advantages of this so-called hybrid learning. And this is something which has to be embraced by all institutions, in particular all medical colleges and healthcare universities. It does give the student enhanced learning experience. It gives accessibility to many more learning materials than what is probably possible to be given in a particular lecture. And it also allows for independent and lifelong learning. Today, if you want to see any surgical video, you go on the net, you will get a possibility to see that quite extensively. So this is something, but we are just trying to collate all these things and bring together for the student to get the maximum benefit. So there are challenges and strategies, and we need to sort of take this up as a university. We have to make the appropriate technology choices, and this has to be proper. There are any number that are available, and you should not be fooled around by getting into anything and everything. Create the appropriate infrastructural needs in the institution. Of course, the infrastructurally, the space required will definitely become much, much lesser, but that is something which also has to be planned. Engage relevant partners to provide support. There's no harm, as rightly told by VC of the Tamil Nadu MGR University. It is nothing wrong in sort of having MOUs with westernized universities, which will share with you some of these readily available resources, and that is something which can also work. And intentionally engaging both faculty and student. This is the most important necessity. None of these things will happen without sufficient training, and I'll show you in 1 or 2 slides how exactly we progressed in our own institution. And there is possibility of continuous evaluation. So in Ramachandra, we created 3 levels of blended learning workshops. One is the basic level, then the intermediate level, and the advanced level, which provides each of the faculty to get chance to understand what are all the possibilities that they can learn in this type of teaching learning. About 424 faculty members have been trained. They use the Moodle platform for the entire exercise. We created a studio in collaboration with IIT Madras, and this is able to sort of give high quality video lectures being created. And there were tools to record the screen, and video tutorials to train faculty members were also tried. So this is the broad login site that is available in our website itself. And when you log in with the number of the student or the faculty, a lot of possibilities can be done. So this is a huge disruptive innovation in terms of education, and COVID has actually facilitated us all through the digital tools, and the competency-based education also coming in just about a year before is helping us in terms of creating simulation-based training, and this has helped us in moving forward. And ultimately, higher education is almost remade in view of the new education policy. And the institutional adaptiveness is one important step towards that. The IT adaptiveness, of course, at the end of the day, we expect that there will be improved decision-making and improved student outcomes as well. I thank you for your attention. Thank you very much for the opportunity.
Thank you, sir. Hats off, sir, for such a meaningful, relevant, practical, well-organized and step-by-step guidance for planning and implementing blended learning in any institution, sir. Being a part of Health Science University, teaching and training is one of the primary roles, as we are producing the next generation of health workforce. As you rightly mentioned, sir, that we are not bogged down by the unprecedented developments around us due to the COVID pandemic. Rather, we have rose to the occasion and continued training of undergraduate medical students as well as the postgraduates. In the process, we have adopted and explored a wide range of online teaching learning methodologies, both for teaching as well as for assessment, and even continued with the traditional teaching learning methods whenever it is required, with the sole purpose of making it useful for the students. Thanks, sir, once again for sharing your views with the audience today. As far as for the given suggestions and raised questions, we'll get in touch with the resource person considering the paucity of time and email you their responses. At the end, I'll end today's webinar extending my greatest regard to all the three eminent resource persons, the Honorable Vice Chancellors, Professor Vijay Raghavan, Professor Sudha Seshayan, and Professor Subhash Chandra Parija, for sparing their time out of their busy schedule and enlightening us about the recent advances amid the ongoing COVID-19 pandemic. I thank the entire webinar team, which has been the backbone of this series and is working tirelessly. I thank all the participants who have joined for these sessions and the IT team and the printing team. Finally, I extend my regards to the SBV webinar team for selecting me to be the moderator for the today's session, and in the process enlighten myself by the talk of three marvelous and erudite resource persons. See you next month once again on the 19th May at 2:30 p.m. Thank you everyone once again. Stay happy and stay safe. Jai Hind. Thank you everyone.